Welcome everyone. Hello. My name is Sabrina Sholts. I'm a biological anthropologist and the curator of the exhibit Outbreak: Epidemics in a Connected World at the Smithsonian's National Museum of Natural History. And I'm joining you all today, not from the museum, but like many of you, I'm joining from home in Washington, D.C. On behalf of the museum, it's my pleasure to welcome you to the final of 3 programs in our series, AIDS at the Intersection of Community, Science, and Policy. It's been a pleasure, it's been an honor to be part of the global observance of World AIDS Day this week and to share in the rich ongoing discussion of issues related to HIV and AIDS. Although this program series is concluding today, several other events related to World AIDS Day are still ongoing, including a virtual viewing of the AIDS Memorial Quilt that is hosted by Whitman Walker Health. And so we're going to share links to that in the chat box so that you can check it out if you want to. For more than 2 years, the Outbreak exhibit has been educating the public, the exhibit as well as its programs, about viruses that spill over from humans or to humans from other animals, about pandemic threats, and about the interconnectedness of human, animal, and environmental health as one health. And now, at this moment, I would like to say thank you very much to the many organizations and individuals who have been part of that effort, who have supported the Outbreak exhibit along the way, and especially those that have provided funding. When Outbreak reopens to the public, as it's been temporarily closed since March of this year, we will have updates that situate COVID-19 among stories of other epidemic and pandemic diseases. HIV has been and will remain at the center of the exhibit. For those of you who have not seen the exhibit yet, that is a story that is literally physically in the center of our show. But despite all the people, perspectives, and experiences of the HIV pandemic that we've tried to represent, there are far more stories than we have space to tell. And so that's why programs like this one have been so important for expanding our ability to tell more stories and bring more faces and voices into the conversation. Today, we're going to hear from 2 people who work at the intersection of HIV with law and policy, a critical arena that strongly influences the success or failure of public health measures. So how this is going to work is that our speakers are going to give brief presentations, and then afterwards they're going to answer a few questions from me, and then questions from you, our audience. So you'll note, if you haven't already, that the Q&A box, that's where we'll be communicating with you throughout the program. We're going to post links in there as they come up in the discussion, and that's where you can submit your questions for our speakers, which I will then ask. So take a moment to locate that Q&A box, which should be either at the top or the bottom of your screen. You'll type your questions in there, and then we'll do our best to answer as many of them as we can. And we're also pleased to offer this program with captions. So to turn on those closed captions for this event, click on the CC button and select Show Subtitles. And use the same menu if you want to turn those captions off. That CC button should be located at the bottom or top of your screen. So with all of that, we're going to get started. So I would like to introduce our first speaker, Greg Millett. Greg is the Vice President and Director of Public Policy at amfAR, the Foundation for AIDS Research. He is also a nationally recognized epidemiologist and researcher with significant experience working at the highest levels of federal HIV policy and development at both the White House and the CDC. Greg is one of the 3 principal writers of President Obama's National HIV/AIDS Strategy, and he also worked on a diverse array of policy issues during his tenure at the White House. A few notable accomplishments include the elimination of the HIV entry ban that prohibited HIV-positive people from traveling to or seeking residency in the United States, and the temporary suspension of the ban that prohibited federal funding for domestic or global needle exchange programs. He also worked with the CDC to adopt a new funding formula for state and local health departments that better aligns funding with current disease burden. Greg has a Bachelor's of Arts degree from Dartmouth College and a Master of Public Health degree from the University of North Carolina at Chapel Hill. He has published over 40 peer-reviewed research papers in leading health policy and public health journals, including JAMA, AIDS, American Psychology, and Health Affairs. Welcome, Greg. Thank you so much. It's an honor. Please take it away.
Great. Thank you so much for the introduction. It really is a wonderful to be here, and I'm looking forward to any questions that people might have. It's also great to share this platform with Jada and other colleagues. Today, I'm going to speak to you about the relationship between policy and ending HIV and COVID-19 epidemics. And to really help us level set, I first wanted to talk about what policy is. So policy really is the general principles by which a government is guided in its management of public affairs. And what policy does is that it outlines what a government is going to do, how it's going to do it, and what it can achieve for society as a whole. Now, this is important because policies can essentially affect effectiveness in fighting HIV, COVID-19, as well as other diseases. And even though policies can be effective, there's also quite a bit of policies that can be bad as well and ineffective. So to just start there, we've had bad policy often replicated in the United States. And what I mean by bad policy are policies when we're in the middle of a pandemic, just like with HIV back in 1987, where we had a ban that was placed for people traveling to the US with HIV. Or unable to establish citizenship in the US if they were HIV positive. Now, why this was a bad policy is because we already had HIV in the US. We had HIV widespread and spreading in the US, and a ban would not have helped banning people coming from other countries. Unfortunately, we replicated that policy this year with coronavirus, where we banned certain countries and people coming from those countries because of fears of spreading COVID-19. But there have been several studies, including several studies by CDC, that showed that COVID-19 was already here and spreading before the ban. So these bans are not effective. They're not effective policy. Bad policy can also last for years and just not be helpful for some of our responses for infectious diseases. So, for instance, there was an outbreak several years ago in 2015 in a rural county in Indiana, Scott County, where there were nearly 200 people who became infected with HIV through injection drug use during an opioid epidemic. Now, part of the reason why this was a bad policy and the reason why people became infected was because there was no syringe services programs in that part of Indiana or any other part of Indiana at that time. Why that's important is because syringe services programs, we already known from years and decades of research, help keep people from getting HIV or hepatitis C if they engage in injection drug use. But it was banned through policy in Indiana and other parts of the US. And there have been several studies that have found that if there was a syringe services program and if there were earlier intervention, then there would not have been an outbreak in Indiana. We would not have seen 200 people who became infected with HIV. And one thing that is very clear is that bad policy can also be expensive. My colleagues and I at amfAR costed out how much it was going to cost Indiana to address this outbreak that was taking place. And when there was only 135 people who were HIV positive, we figured, well, let's go ahead and cost this out to how much it would cost when 200 people become HIV positive. So with 135 people who are HIV positive, including 90% of those people being co-infected with hepatitis C, in the absence of a syringe services program, which is only $135,000 per year, just the treatment costs alone for those 135 people would be $48 million, or 357 times the cost of a syringe services program. When you cost it out to 200 people becoming infected, 170 of whom are co-infected with hepatitis C, the cost ballooned to $71 million, or nearly 530 times the cost of just having an annual syringe services program. So we see how cost effective a syringe services program could have been in preventing this outbreak. And unfortunately, it was something that was not followed. And we had these unnecessary infections that have taken place. We see a lot of the same things that are taking place right now with masks and the lack of a mask mandate and the number of infections and unfortunately the number of deaths that are taking place across the US for COVID-19. The other thing that you see with bad policy is that sometimes you can really graph how it affects specific parts of the US. So for instance, the CDC did an analysis to look at those counties that were vulnerable for another outbreak of HIV if they didn't have syringe services programs. And they found 220 counties where you could find another outbreak. And then they mapped where the syringe services programs were. And as you can see here, syringe services programs were in places that were not included in those 220 vulnerable counties. So policy certainly has implications in terms of HIV epidemics. It has implications in terms of health, and bad policy, unfortunately, can put people at greater risk for various diseases. Now, this is basically from a paper that I just published in a medical journal where I was looking at a lot of the intersections between COVID-19 as well as HIV. And it really shows just many of the different policies that can amplify specific issues that place people at greater risk for COVID-19 as well as HIV. And I'm only going to talk about a few of these in greater detail. But one of them that we definitely know about is access to healthcare. We know that the Affordable Care Act was passed during the Obama administration. A component of the Affordable Care Act is Medicaid expansion, which basically allows people of low income to have greater access to healthcare. And you can see that there are 14 states that have not expanded Medicaid versus the rest of the US. Those states that have not expanded Medicaid, you see that there's higher rates of people living with HIV who are uninsured as compared to those states that have expanded Medicaid. And in those states that have expanded Medicaid, you see that there's a greater proportion of people living with HIV who are now covered under that Medicaid expansion program. Now, that's important because we know that Medicaid expansion is associated with greater rates of HIV testing, greater access to opioid addiction medications, greater viral suppression, meaning that people are less likely to transmit HIV if they're on drugs and if they're virally suppressed. All of that is associated with greater Medicaid expansion. But unfortunately, of those 14 states that have not expanded Medicaid, half of those states, 7 of them, are part of the president's plan to end HIV. Now, we're not going to be able to end HIV, particularly in these 7 states, if people do not have access to healthcare, and particularly if people living with HIV don't have access to healthcare. So that's an example of bad policy. And why that's important is not only for HIV, it is also associated with COVID-19. Many of us have heard about the plight of essential workers in the US and the fact that essential workers are more likely to be prone to COVID-19. There was an analysis that was done by the Center on Budget and Policy Priorities where they found that over 650,000 uninsured essential workers can get Medicaid coverage if those holdout states adopted Medicaid. Now, that's important because that would mean that it would reduce the likelihood of COVID-19 infection or HIV infection if those groups are able to get access to Medicaid and to health insurance. And the one thing that we're seeing that is helpful, even in the era of COVID-19, is because of so much destruction with the economy, that those states that are really having some fiscal issues are now looking at expanding Medicaid to really try and cover the costs for COVID-19. So we've seen it in Missouri, in Oklahoma. We see that Mississippi is looking to do the same thing. Now, the other thing that we see where policy is relevant is economic relief. Right now, many of you are hearing in the news about economic relief for COVID-19 and the $900 billion package that is being debated in Congress right now. Now, why that is so important is because we know that housing is also associated with health and disease in the US, and particularly infectious disease. And with the COVID-19 recession that we're facing right now, there's going to be a greater number of Americans who are facing losing their homes, being evicted from places that they're renting, or somehow missing out on their mortgages and being evicted from their homes as well. And that has implications for the HIV epidemic as well. And what I mean by that are some data that have been published that looked at the degree to which homelessness is associated with poor outcomes, health outcomes for people living with HIV. Now, as I mentioned beforehand, people who are HIV positive, if you're taking medications, those medications make sure that you're virally suppressed, meaning that there's less virus in your system. If there's less virus in your system, you're less likely to transmit HIV. So this is a study out of San Francisco that looked at degrees of homelessness among people living with HIV. These were people who are renting to own, all the way down to people who are homeless and living outdoors. Notice that the rates of viral suppression were highest among the people who had roofs over their heads. But then when you got to people who were homeless and outside, the rates of viral suppression were very low, meaning that these were people who had poor health outcomes. They were more likely to transmit HIV. So when we're looking now at what's taking place with the COVID-19 pandemic, and particularly with the recession, we're probably going to see more homelessness, which is probably going to impact HIV rates, unfortunately, in the US. One other study from San Francisco found that people who are homeless, who are diagnosed with HIV, were 27 times more likely to die from HIV as compared to somebody who's diagnosed with HIV and they have a roof over their heads. So homelessness is certainly an important component and certainly a policy that needs to be considered when we are trying to fight HIV as well as other diseases in the United States. Another way that we see that policy is associated with disease is residential segregation. Now, many of you probably know that back in the 1930s, during the Depression, that there was a federal agency called the Homeowners Loan Corporation that basically looked across the United States, spread apart these maps, and looked at counties where they should invest in and counties where they shouldn't invest in the aftermath of the Great Depression. When you actually take a look at these documents, some of those maps actually say we shouldn't invest in this county because it has too many immigrants, it has too many people of color, it has too many types of undesirable people. Well, that actually had major consequences for disease as time went on because there was more investments going into places that the homeowners loan corporation said that we should invest in versus other places. And what you could see even today is that it has ramifications in terms of racial segregation. So those counties in the US that are more diverse, only 60% or less white, actually have more diagnoses of COVID-19 as compared to those counties in the US that are 88% or more white. And this is part of an analysis that my colleagues and I did earlier this summer when we were trying to take a look at residential segregation and the types of disease that's taking place. Unfortunately, you find the same thing with HIV. So those counties that are more diverse, you find higher rates of HIV as compared to those counties where it's primarily white in the United States, where you see lower rates of HIV. So residential segregation as a policy, even something from as far back as the 1930s, still lives on today in terms of the way that disease is distributed, and particularly HIV. Now, at this point, I've been talking about policies that have been bad. There are also great policies and good policies as well that are helpful for HIV as well as other health outcomes. So this is from an analysis that CDC looked at a couple of years ago, where they're looking at variation in states in mortality among people living with HIV and what was associated with lower death rates for people living with HIV. And what they found is that death rates among people living with HIV were lower in states where there were higher levels of healthcare coverage, where there are higher levels of anti-discrimination laws, and where there were higher levels of viral suppression among people who were in the Ryan White program. This is a program for lower income people living with HIV that provides some healthcare. And what they basically concluded is that states can influence HIV outcomes through programs and policies. So this is not a fait accompli. We can, through policy, actually influence the health of people, and particularly the health of people living with HIV. Now, before I close, I wanted to talk about the fact that what we're seeing with HIV, what we see with COVID, what we're seeing with the opioid epidemic, as well as hepatitis C and other epidemics, is that these epidemics do not necessarily take place in a vacuum. A lot of them are interrelated, and it's not just an epidemic, it's actually something that we call a syndemic. These are multiple overlapping epidemics that are placing many of the communities at higher risk for many of these same diseases. And the policies that we have can't just focus on one of these issues. They need to make sure that they understand and see the interrelatedness of many of these epidemics so that we can address them jointly. Now, an example of the way that we have addressed this jointly in the past, when I was in the White House and I was fortunate to be a part of the Office of National AIDS Policy, they hired me from CDC. I was a scientist there at the time, and they needed a scientist to help build the scientific underpinning for some of the policies for the National HIV/AIDS strategy. And part of that underpinning was to realize that HIV is a syndemic, that we're dealing with multiple other issues that affect the lives of people living with HIV in terms of poverty, homelessness, criminalization, and many other issues, and distilling that into a compatible policy document that can guide our policy response nationally as well as domestically for the HIV epidemic. And thankfully, we've seen with now President-elect Biden that he's going to continue the national HIV/AIDS strategy and update it for his administration. Now, before I end, if you want to learn more about how policy it really affects HIV, we've built a database at amfAR. You can see it at ehe.amfar.org, where it really marries a lot of the epidemiological disease data across the US, all the way down from the state level to the county level, and then looks at various policies from criminalization, discrimination, rates of poverty or unemployment, where you can actually see rates of disease in conjunction with some of these policies, and you can map things out in terms of trend analyses and everything else. So it gives you a firmer picture of what's really taking place and how policy can ultimately impact health in the United States. So with that, I wanted to thank you for your attention and also give you a reminder that if you ever meet a future president of the United States, make sure that you wear a suit and tie combination that would withstand the test of time rather than colors that are really problematic. But looking forward to any questions or comments that you might have. And thank you again for the opportunity to speak today.
Oh, thank you so much, Greg. That's fantastic. So folks, yeah, anyone in the audience, if you have a question, please start putting that into the Q&A. We're going to move on to our next speaker, and then we'll be coming back to questions afterwards. So thank you, Greg. Okay, so Jada Hicks is a supervising attorney of criminal justice initiatives at the Center for HIV Law and Policy. She earned her Juris Doctor degree from North Carolina's Central University School of Law. While at NCUU, she was certified in civil rights and constitutional law. She received her Bachelor of Arts in Criminology at North Carolina State University. Prior to joining the Center for HIV Law and Policy, she served as an inaugural judicial fellow for the Administrative Office of the Courts. While there, she provided independent and confidential legal research and writing support to more than 370 judges who comprise North Carolina's Superior and District Courts. Previously, she worked as an assistant district attorney for the Pitt County District Attorney's Office. She prosecuted cases ranging from drug offenses to DWIs. Thank you for being here, Jada. Welcome, and please take it away.
Yes, thank you so much for having me and for that introduction. I'm so excited to be here and share with everyone a little bit more about HIV criminalization and law and policy. I am going to go ahead and share my screen so that everyone can see my PowerPoint, if you'll just give me one moment. Can you see when I share my screen? I apologize. I just want to make sure.
I'm not seeing it. If you need help from our behind the scenes crew to share your slides for you and just to prompt them as they go along, I think that's fine.
If we could do that, it seems that for some reason it's not prompting me to.
Okay, they're on it.
So much.
All right, so go for it.
So again, I'm Jada Hicks. I'm from the Center for HIV Law and Policy. We are based in Brooklyn, New York. I have not only my email address in case anyone has any questions, but our website for any of the resources that I'm going to be using as well. Next slide, please. So Greg talked a lot about legal policy, and I'm going to be talking about the legal landscape of HIV criminalization and what exactly that looks like throughout the United States. So for the scope of HIV criminalization, there are 32 states that have HIV-specific criminal laws and impose criminal penalties for people that are living with HIV in some capacity. So these laws impose anywhere from misdemeanor or felony level punishments and explicitly target people that are living with HIV. They can specifically be found in the criminal codes, but they're also found in public health codes, and it really depends on how the state decides to criminalize people and prosecute people living with HIV. Some of these laws define criminal offenses for exposing others to HIV. Others outline harsher penalties for people living with HIV for acts that are already considered criminal. So for instance, it is already a criminal offense to engage in prostitution. However, if you engage in prostitution and you're a person living with HIV, it goes from a misdemeanor level punishment to a felony automatically just based on your HIV status. So over half of the states, 25 states, allow people living with HIV to also be prosecuted under general criminal laws. So there does not have to be an HIV specific criminal law. An example of this would be aggravated assault, where your HIV status is considered a deadly weapon. We've seen even bioterrorism laws or attempted murder charges for people living with HIV. There are 6 states that require registration as a sex offender, and that is regardless of whether it's basically a sex offense if you do not disclose your HIV status and you engage in sexual contact. That is all it takes in a majority of those states to be described or listed as a sex offender and then have to register on the registration. Next slide, please. So when we're talking about HIV criminalization, what exactly is that and what does it look like? So HIV criminalization is the creation of new criminal laws and increased penalties targeting people diagnosed with HIV for conduct that is either legal or less severely punished for individuals that have not been diagnosed with HIV. All of this is based on the outmoded and outdated belief that HIV is a highly infectious and fatal disease. So previously I gave the example for prostitution, another example of how HIV status and HIV can be used as a basis for enhancing penalties or making something that is a less severe crime more severe based on HIV status would be sentence enhancements for individuals that are incarcerated. So for instance, it is a crime already if you throw urine or feces or spit or blood on a correctional officer. If you do that and you are HIV positive, it is automatically increased in some states to a felony level punishment. And you will face punishment regardless of whether HIV is transmitted. And even though we know that, for instance, spit or urine, you're not going to transmit HIV that way, it does not matter and the actual risk is not taken into consideration. Next slide, please. This map is actually on our website, hivlawandpolicy.org. I think it's a great breakdown and overview of the United States. It is also color coded and breaks down whether a state has an HIV specific criminal law, which would be the deep red states with sentencing enhancements. That's the light orange, and then the darker orange is states where they don't have a specific HIV crime listed on the books, but you can be prosecuted under a general criminal law. The green balloons are states that have reformed or repealed their HIV law in some capacity. And the yellow balloons are states that require sex offender registration. So those 6 states that require sex offender registration. So for instance, if I were to pull a state out, if we look at Indiana, Indiana not only has an HIV specific criminal law, they also have sentence enhancements, and they also, people living there with HIV can be prosecuted under the general criminal code. So this is just a nice breakdown and snapshot of HIV criminalization throughout the United States. Next slide, please. So HIV is not the only disease, communicable disease that is criminalized. And this is what Greg was talking about when he was discussing this as a syndemic issue. So in a number of states, 12 to be exact, they also criminalize viral hepatitis. So it can either be specifically enumerated, the type of hepatitis, for instance, hepatitis C or B, or it can just be generally viral hepatitis that is criminalized. How are they criminalizing hepatitis? It's either through sex, needle sharing, or bodily fluid exposure. That was what we were talking about in the correctional setting. or they can have a law that's just broadly written enough that viral hepatitis can be swept in and people living with viral hepatitis can be prosecuted there. Why this is important is because it really shows the overlapping nature of our work in HIV law and policy. So there's this intersection with opioid injection drug users, with sex workers, with hepatitis, and with HIV. And so I just wanted to highlight that there are other diseases that are stigmatized besides just HIV, and we need to work on all of these areas in order to end the epidemic. Next slide, please. This is a useful tool that I wanted to include from our website that breaks down exactly what an individual can be prosecuted for, what type of conduct, whether there's a sentence enhancement, whether the law is in the public health code or the criminal code. So for instance, if you go to Arkansas here, you can see that sexual exposure is criminalized, spitting, biting, blood exposure is criminalized, needle sharing is criminalized. So if you ever need a quick reference to go through, we have each state listed and exactly what is criminalized in that state. And we just updated this chart this past July, so it's completely up to date. And I think it's a great tool to give you an overview of exactly what is criminalized in each and every state and where you can find those criminal laws, whether it be in the general criminal code, in HIV specific law, or in the public health code. Next slide, please. So I wanted to give everyone an example of what I'm talking about when I say HIV is criminalized, either with a specific criminal law or in the public health code. So I like to use Ohio as an example because HIV in Ohio is criminalized both in the public health code and they have an HIV specific criminal law. So the HIV specific criminal law is under a felonious assault statute. And it's basically that if you are HIV positive and you engage in sexual contact with another person without disclosing your status first. So that is a felony and you can serve up to 8 years in jail. However, in the public health code in Ohio, they also have a statute in there for exposing others to contagion. And the way that that law is written would mean that a person living with HIV could also be prosecuted under the public health code for a second-degree misdemeanor and spend up to 90 days in jail. And I want to point out there that contagious disease in Ohio is not defined, and it has been interpreted by courts to include venereal diseases and HIV in claims brought in tort law. Next slide, please. So I think it's important to point out that HIV criminalization is in conflict with our public health goals and our goal of ending the epidemic. There's no evidence that these laws or prosecutions deter any sort of quote unquote risky behavior or more high risk behaviors. No evidence that these laws have reduced incidence of HIV diagnoses. There could be a disincentive to learn your HIV status because knowledge of your HIV status is one of the elements that has to be met in order for individuals to be prosecuted. It also alienates patients from healthcare providers. It sends a one-sided message regarding sexual health and prevention and responsibility. It really should be on both individuals to take responsibility for their own sexual health, not just the person living with HIV. It disproportionately harms our already marginalized communities, particularly our Black and brown women and sex workers. And government-endorsed stigma is really at odds with public health campaigns, and we see that with the End the Epidemic campaign. We can also see this with what's going on now with COVID and kind of this battle as to whether or not we should criminalize COVID. COVID-19 is a public health issue, and so we should be approaching it in that way. And we really should be taking lessons that we've learned from the HIV epidemic and applying them to how we treat and combat COVID-19 and whether or not we take a carceral approach or a public health approach. Keeping in mind that everything we do can work to promote stigma, and stigma will weaken an effective response to any sort of stigmatized disease, whether it be HIV or COVID-19. Next slide, please. So what are the problems with HIV prosecutions? Largely, there are strict liability crimes. What that means is that intent to transmit or intent to cause harm is very rarely required. In fact, it's usually not even a consideration when these laws are written. Transmission is not required. So any kind of activity that's used as sex within that state and allegations of non-disclosure are enough for prosecution. Again, actual risk of transmission is largely irrelevant. So we are criminalizing modes and risk of transmission that we know pose negligible to no risk of actual transmission. So for instance, spitting, you're not going to transmit HIV by spitting on someone. However, it's still criminalized and you can still face felony level prosecutions. Proof of disclosure is often the only defense. So again, that's going to be one person's word against another person's word. That's the only defense in court. A he said, she said, or a she said battle going on in court. And I wanted to point out here as well that risk reduction measures are not always a defense. So whether or not a person uses a condom, is on medication, has achieved viral suppression, it isn't taken into consideration. And also we are seeing severe and disproportionate punishment based on the offense. So we're seeing people being sentenced to a number of years, oftentimes more than someone would for manslaughter for having sex without disclosure, even though they did not transmit, nor did they have the requisite intent to harm. And that was one thing that really shocked me coming into this field, coming from a prosecutor's background, because most laws that you see, there's always some sort of intent element, intent to harm there, and you just don't see that in HIV prosecutions and HIV specific criminal laws. Next slide, please. Next slide, please. So this is a timeline of state reforms and repeals of HIV criminal laws that we put together. It gives you a broad overview of which states have reformed and in what year and what specifically they reformed in their law. The next few slides that I have, I just wanted to give a few quick examples of what states have done and how they've approached reform efforts. So next slide, please. And for these, if you'll actually click again, there we go, thank you. So for Texas, it was the first state to repeal its HIV specific law. And so a lot of times people will say when we're reforming HIV criminal laws, why don't we just get rid of all HIV criminal laws? What's the problem with doing that? And the problem is that repeal does not end prosecutions. This now subjects people living with HIV to general criminal laws being used against them for prosecution. So again, attempted murder or aggravated assault were the examples that I gave previously. And that is what you see in states like Texas, where they can still use the general criminal laws. So repeal is not always the best option. Next slide, please. In North Carolina, something else that we see in states is creating a viral divide. So there's been a lot of talk about U equals U and viral suppression, and when you're virally suppressed, not being able to transmit. So they wrote that into the law, however, as the linchpin of whether or not someone would face prosecution. If you've been virally suppressed for 6 months and your partner is taking PrEP and your partner is also HIV positive, you don't have to disclose. However, we need to keep in mind there are a number of barriers to viral suppression. Socioeconomic status, there are racial factors and implications that come into play as well. So there is a lot of intersectional nature here in this work that is not taken into consideration in terms of who can even achieve viral suppression and has access to medication, access to doctors, and all of those factors come into play. And so noting that U equals U and whether or not someone is virally suppressed should not be the linchpin of prosecution, because it creates a viral underclass for those that are not able to achieve viral suppression. Next slide, please. Washington is the latest state to have a victory within this year. Washington state reform. We see that they included specific intent for transmission to occur, for prosecution to occur, there must be transmission. So that was not the case before. We also worked in a number of affirmative defenses, including not only disclosure, but practical means to prevent transmission. So condoms, whether or not you're on treatment regime and sticking to that treatment regime. So CHLP worked with Washington. It took over 7 years to get a reform passed. But what we saw was them incorporating a lot of the lessons that we learned from other states in order to make an effective new law for HIV and for people living with HIV. They did retain felony level punishment. However, it's when a person living with HIV transmit, and again, transmission required to a child or vulnerable adults. And that was already considered a sex offense. So that's how they decided to compromise on that issue. So I just wanted to give a few snapshots of what states have done and how they've approached reform as well. Next slide, please. So proposals, how do we move forward in our policy world and in our legal landscape in order to combat HIV criminalization? So the most important piece is really follow the research. That's what matters most. Data on enforcement, the Williams Institute has put out a number of reports on states and who is most affected and bears the brunt of prosecution. We need to take that into consideration when we are trying to reform these laws. Don't settle for reform that leaves them behind. So we should not leave behind our marginalized communities. That means sex workers, that means injection drug users, that means our Black and Brown communities, our trans communities. Everyone should have a seat at the table. We need to promote leadership and meaningful engagement of people living with HIV and at risk of HIV and viral hepatitis, their communities and those in other movements with shared concerns. HIV literacy campaign. So we really need to focus on our educational aspect of this, and we need to do that preemptively. So we really need to educate not only the community, but stakeholders on roots and risks of transmission and where science is today and how far we've come, and that HIV is not a death sentence. We do not need to undermine cross-disciplinary projects and issues. So for instance, a lot of times when we are reforming HIV criminal laws, legislators will try and make it a compromise to say, we'll make the law so that it's not HIV specific by including other diseases. So for instance, they'll include viral hepatitis, they'll include tuberculosis. That's not what we're looking for when we're trying to reform a discriminatory law. We don't want to broaden the definition so that it includes other diseases and also increases prosecution for people that did not face prosecutions previously. We really want to try and cabin prosecutions. And so we want to make sure in any sort of reform that we do that we're not undermining these other intersectional areas of our work. We also need to have collaboration with a broad group of stakeholders. So for instance, in May of this year, CHLP worked with national law enforcement, public health officials, and criminal legal organizations and experts, including the National Prosecutors Association, to issue a joint statement on public safety pathways for criminal justice system responses to COVID-19. So I know a lot of times people think, it's going to be difficult to get certain stakeholders on board, like the public health department or national prosecutors, but we've actually had success in reaching out to them and working with them on reform proposals. And we saw that most recently with COVID and the call to release individuals who have committed lower level offenses from carceral settings so as to stymie the spread of COVID-19. Next slide, please. This last slide is just where all of my resources are coming from. Again, most of these are on hivlawandpolicy.org, and you can find laws for any specific state. We have the first source book that is a comprehensive look at HIV criminalization throughout the United States, and we have an excerpt for each and every state that outlines how HIV is criminalized within that state. And also stay tuned because we're coming out with a hepatitis toolkit. And so that'll also dovetail nicely with the source book because it will outline which states criminalize viral hepatitis and how. We've got our task consensus statement, treatment as prevention, our PJP guiding principles, which are how we should approach HIV reform efforts. So there shouldn't be HIV specific laws or no disease specific criminal laws. We want to see no felony level punishments. We want to see proportional punishment to the crime. We want to require intent to transmit and intent to harm. And so you can find a copy of those principles there. And also the chart that I referenced that shows you which states criminalize HIV and how. So you can find those resources there. Thank you so much.
Thank you, Jada. Thank you to both of you. Greg, I invite you back to our conversation. Jada, stay where you are, because we are going to now start talking about all of this. I'll remind our audience again, like now's your time. If you haven't already, please start giving us your questions. But I get a few to start. That's my privilege as your moderator. And Greg, I wanted to start with you. Yeah, I really appreciate your discussion and very blunt language about bad policies and good ones, right? I mean, I think that that's a really helpful way to put it. And you gave so many examples of both. I'm wondering, are there some really good examples of a change in policy, maybe a bad policy being improved or replaced based on science, based on a syndemic perspective, based on some way we've advanced since it was created, that has improved the lives and the health of people with HIV?
Sure. So, I mean, one of the ones that's actually a really good one is actually looking at syringe services programs, which I mentioned beforehand. One way that actually changes bad policy quickly is when there is a threat of an epidemic. So up until about 2015, there were 220 syringe services programs in the US. Now we have well over 340 or so. And where we saw that rapid change was right after the Scott County outbreak. So there were neighboring states, not just Indiana, but neighboring states around Indiana that saw what was taking place in Indiana, and they had not implemented syringe services programs. But then they saw how much it was costing Indiana. They also saw the number of people who were becoming infected, and they said, well, maybe it's time for us to do this. And you saw a rapid rise in syringe services programs, which is great. But the thing is, it shouldn't take an outbreak for us to get there, to change policy. This is something that we knew in terms of the public health data for 20 years, and we should have been able to change that policy long beforehand. Other places where we see changes in policies that affect people living with HIV is certainly, changes in housing policies that we've seen. So for instance, there was a time where it was more difficult for people living with HIV to find access to housing before we could really have that as part of the Ryan White program. Now, because it's an integral part of the Ryan White program, we see that people living with HIV who are in Ryan White actually perform better with their HIV outcomes, not only because of housing, but because they also have access to healthcare. They have transportation to their health services. All of these policies that address some of those social determinants of health that I talked about that are really problematic for many people, particularly people at risk for HIV. So there's different places where we're seeing some improvements in policy, but of course, there's a lot of room for more, exactly as Jada had exemplified in her presentation.
Yeah, better to be proactive than reactive, right? Or wait for these worst cases. For Jada's question that I'd like to ask her, we're actually going to try something new for us. Jada, I'd like to have you respond to a video clip where we have a speaker that describes a past experience being fired from work due to discrimination. And so this clip is of Michael Shilby, a person living with HIV, and was recorded by Whitman Walker Health in 2016 as part of their ongoing oral history project. And we're going to share a link to this video and more information about the oral history project in the Q&A. Ashley is going to play that for us. Oh, can't hear it. I think we will have that up again in a moment.
When they asked me to resign from the hospital because I was gay and HIV positive, I just said, okay, and left. And then my friend said, no, you need to seek legal intervention. And I thought, okay, I did. And the lawyer told me we can prove that the hospital, well, they're idiots. And you can get your job back or you can go out on disability. And I thought, well, because I too got the same information. You have too few years to live. So I thought, okay, if I go back and get my job, even though it's been eight years I was there, they would still document and pull the plug and I'd be fired. In the beginning.
All right, thank you, Ashley. So Jada, could something like that happen to someone today? And if so, what options would that person have? legally?
There are protections in place actually to protect individuals living with HIV against discrimination in the workplace. So Title I and II of the American with Disabilities Act. Title I applies to all employment non-governmental agencies. Title II, government agencies, state and local. And then the Rehabilitation Act of 1973 applies to federal agencies and individuals that receive federal funding. So for a hospital, if they take Medicaid or Medicare, that would be receiving federal funding. So it would apply in this video clip in this instance as well. There also are a number of state laws that ensure HIV positive workers have job security and reasonable accommodations when necessary and are free from a workplace surrounded by harassment or the stigma that goes along with HIV. Also dealing with sexual orientation, that is a protected class, as specifically in DC as well. Gender identity or expression are you are prohibited from discriminating against individuals based on their gender identity as well as their gender expression. So that would fall into the sexual orientation category, and courts have ruled that sexual orientation falls under the sex category, and therefore those individuals should not face discrimination in the workplace.
Thank you. I think we're going to start taking questions from the audience. And again, if anyone wants to, please type a question into that box. So we've got a question here from Michael, and I'm not certain, I don't know which one of you maybe spoke to this issue, but please, maybe that'll become apparent. Did I understand this correctly, that in 6 states, you have to register as a sex offender just because you are HIV positive? Or is this specifically for non-disclosure?
It depends on the state. It could be for non-disclosure. It's not just if you're living with HIV, you have to register as a sex offender. You have to engage in some sort of conduct. So a lot of those states, it is enough that if you have HIV, you do not disclose your HIV positive status, you have sex with someone else, you don't have to transmit, you don't even have to mean to transmit. That is enough that if you are convicted, you would have to register as a sex offender. And you're on mute, I'm sorry.
It happens. Okay, Greg, I have a question for you. We've been talking a lot about statewide differences. We were just and have been, during this program. Are there notable ways that HIV policies, like at the federal level, maybe, or just across the board in the US, differ from other countries that we should be thinking about or looking at or be aware of? Now you're muted.
I'm doing the same. Hi there. Yeah, we have different policies that are somewhat problematic as well between us and other countries. So for instance, some of our policies in terms of reporting or surveillance are far behind other countries. So we not only see this for HIV, but we see this for COVID-19. The fact that we are not able to get really good data in terms of race or ethnicity or breakdown of those data. In the UK, all of those data are complete. They have a very different healthcare system, but that reporting is complete. They have information that is up to date on all of these data by race and ethnicity. Even just surveillance data, basic surveillance data that we have for HIV, sometimes it takes us as much as 2 years to get those surveillance data. So for instance, even though it's 2020, the data that you see for HIV on our website for CDC and HIV diagnoses are from 2018. And part of the reason for that is that there's so many differences within states on how they collect data. There's so many differences in the capacity to clean those data that it takes the CDC 2 years for us to get those data in a good enough form to really understand what's taking place. In other countries, as UK, Canada, you get those data almost instantaneously. You don't have that lag in time. There are other policies that are also very different. There's more of a safety net system in other countries that are really good cushioning for people who are affected by various social determinants of health, such as poverty, such as lack of transportation, not having access to healthcare, that the US doesn't necessarily have, except for the Ryan White program. So we certainly see differences in people living with HIV in some countries as compared to the US. And there's certainly room for improvement that I'm hoping that we could all work toward as we try to eliminate HIV transmission in the US.
I mean, and that's actually, that's a good lead in to the next question, which is, sort of looking to the future. And of course, we are now in a transition, right? We'll be in a new administration in just short amount of time. And this is a question for both of you. And maybe I'll ask Jada first, and then I'll ask Greg to also give an answer. If you could sit down with this new administration, maybe you will. But in that kind of with that opportunity, what would you tell them is most needed or most useful in tackling the HIV epidemic in the US?
Oh, there are so many things. I mean, what most obviously comes to my mind is funding and education, because without those pieces, nothing else works. But I think what's most important is when Greg is talking about social determinants to health disparities and whether or not someone is more at risk for contracting HIV. So it's really, we often have a myopic focus when we're talking about HIV. And we really need to look at it more holistically. So, if someone is worried about joblessness or homelessness, it's a little bit difficult to focus on getting on PrEP or even getting on medication to suppress the HIV virus within your system. So I think funding for a variety of programs, federal bill about HIV criminalization and how it is a public health issue and how we should not be using the criminal law to address those issues. I think syringe service programs, decriminalizing sex work. The list goes on and on. Greg, I'm not sure if you feel the way, but there's just so many things that I think all tie in together that need to be addressed in order to really end the epidemic.
Sounds like there's a lot of work to do. Yeah. Greg, how about you?
I appreciate it. Exactly everything that Jada had mentioned. There is a lot of work to do, but the good thing is that we can do it. We have the tools and we have things that we can do that can do it. And we demonstrated by the reduction in mortality, a 50% reduction in mortality, that we can make gains in addressing HIV. So some of the things that I would say would be, housing. We're going to go through this unprecedented time where a large number of the American public is going to be suffering. There's going to be food insecurity. And we know that housing is associated with greater rates of HIV transmission. So we want to make sure that we keep people housed. The second thing is access to healthcare. I mean, right now that's going to be debated in front of the Supreme Court as to whether or not we're going to have the Affordable Care Act in the next few years, and whether or not we're going to essentially kick 20 million Americans off of their healthcare. We know that having access to healthcare is integral to ending the HIV epidemic. We need to make sure that people still have access to healthcare. The last thing that I would say that's really important as well is that whenever there's a new innovation, a new health innovation, communities that need it most get it last. And that's a problem. We need to move those communities to the front. So we're seeing that right now with COVID-19, the innovation being testing for COVID-19, which was placed in communities that were not communities of color, who are more likely to get COVID-19. We need to make sure that we change those types of things. We see it with HIV, with pre-exposure prophylaxis. It's a pill that you take every day that keeps you from getting HIV. People who have access to the pill are people who have insurance and low risk of HIV. We need to make sure that these types of new innovations that come online are actually going towards the communities that need it the most. And that's something that we can rectify through policy.
Thank you. We are running out of time, but we can take one more question. We've got a question from Alice. I'll direct this to you, Greg, and then Jada, you can chime in if you want. What do you suggest we do to make reporting by states more uniform and speedier?
Sure. I mean, my answer is really simple. We have to invest in public health. I think the thing that's come across very clearly with the COVID-19 pandemic is that we have not invested in our public health infrastructure. And right now that infrastructure is drowning with dealing with the COVID-19 cases. It's the same thing with HIV. We have to invest in the infrastructure at the state level. That infrastructure has been starved, and because it's been starved, we've lost as many as 4,000 or 5,000 healthcare workers over the last 10-year period in these states alone. So we need to make sure that we invest in public health, that we make it easier and capacitate those states so that they could do the type of work that's needed. Right now, you'd have in some health departments, one person who's responsible for overseeing HIV for that state, hepatitis C for that state, as well as another disease. That's just not tenable. We need to make sure that we have more people who can do this type of work so that we could get more in-time reporting from the state level to the federal level.
One thing that I'd like to add to that, Greg, is also I think that we need to work on medical mistrust. Part of the reason that I say that, and especially in our Black and Brown communities, is that for HIV criminalization, for example, in Arkansas and Missouri, your files that are typically confidential can be turned over in a case and used against you in prosecution. And if individuals know that, like I have anecdotally heard that people have opted out of COVID-19 tracing because they are HIV positive and they know that their medical records may be used against them one day in court. And so I think we need to think about those aspects as well. It's not something that maybe the wider audience knows about. But they're nervous that that could be something that the government could try and do with COVID-19 tracing as well. So I really think building back that trust, and I think that starts with the infrastructure and messaging and education within our communities as well.
Thank you so much for that, Jada and Greg. And we're running over time now, and you all probably have more events and engagements. And we're going to now start to close. And I just want to thank you both again for being with us today. Such a nice and really informative and important ending to our series this week. Thank you to the audience for joining us. I want to give a special shout out to the many people who are behind the scenes, who you saw working magic as we went through this program, and others this week and previously. Ashley Peary, Robert Costello, Vin Hill, Cassie Sodergren, Crizia Fernandez, Adriana Skibor, and Naima Mohammed. Thank you all for your work as well. There are so many folks at Natural History at the Smithsonian who are so passionate about these programs, especially in this period that we've been closed. I have to say personally, being able to still reach out and give people information and connect them with experts and to be able to direct questions to places they trust and people who can best answer them is really important. And so it's been an honor to be with you as your moderator. We're gonna be back with more outbreak programs in 2021. For those of you who haven't been able to see the exhibit yet, when we do reopen, hopefully soon, we will be open into 2022. You've got time. Please come visit, check it out. Details of future programs will be published on the M.P.H events page, which will be shared in the Q&A box. And please take the survey that's going to pop up once you leave this Zoom webinar. That's going to help us continue to improve these programs and bring them to you in the best way that we can. And so with that, I will just say thank you again. Take care, be well, stay safe and healthy, and have a great day.